Thank you very much, Professor Schlemmer. It's a great honor for me to be here. As the initiator of the European randomized study of screening for prostate cancer, and as a person who believes that the at least 30% reduction in prostate cancer mortality that the study is showing should become available for general populations, it is crucial for me to participate, and we're participating actually in the development of the techniques that are driven by your group here, which are the MRI technique that will hopefully avoid the issue of overdiagnosis. And that is just my brief introduction. The diagnostic world of prostate cancer has changed dramatically. These are some older reports, but they are still very valid. The National Institute of Health interview study has been reported by Lu Yao in 2003, and it showed in a large number of men that depending on age, there was a rate of PSA testing of 24 to 37%. The California Men's Health Study showed a 75% rate of testing in 84,170 men. And in the Netherlands, we are seeing a high rate of testing, which has increased further, obviously, since 2006. And this is an increase over time in the Netherlands. You see again by age the percentage of men who get tested. And again, this is reported in 2006, and the numbers have increased after that. So what happens to the stage distribution if we apply screening? This is a brief comparison of the T classification of cases that were detected in the screening study Rotterdam in the first round of screening, and we compare it to the population-based Amsterdam Cancer Registry. Please focus only on two columns. This is the T1 and the T4 M+ column. You can see that screening improves dramatically the diagnostic rate of T1 disease, which is the locally confined usually PSA detected disease. And you can also see that there's a dramatic decrease in the proportion of cases that present with high stage or metastatic disease. So this is a good start, were it not that we know that we're overdiagnosing in this group a very large proportion of men. Now, the biopsy evidence that we have is not really the crucial evidence. Crucial evidence is evidence that would be produced by the pathologist on whole mound sections, either detected by autopsy or more easily and more quickly at radical prostatectomy. This shows the data of 550 radical prostatectomies that were conducted in the framework of the ERSPC study Rotterdam. And what you see here is a comparison of PSA levels with the proportion of minimal disease. And you can see that somebody has a PSA below 3, the chance of having minimal disease is almost 70%. And that fortunately decreases with rising PSA. So this information will be very important for us to identify the correct PSA cutoff value, but also to identify the proportion and the type of men that are overdiagnosed and that may require different treatment or no biopsy at all. And if I say no biopsy at all, that is really what our preference is. The MRI should lead us to a situation where we can completely avoid biopsies, and that is now claimed at a rate of 25 to about 45% in various studies that are conducted at various institutions. And unfortunately, a large international study is still missing on this. So how about treatment and treatment options? This is a slide I like very much. It's taken from a paper by Dr. Kupperberg in 2010, and it shows the prognostic score that was designed by this group, the Capra score, and the proportion of patients that are treated by various treatments. And I'd like you to concentrate on the radical prostatectomy color and the androgen deprivation color. That's the endocrine treatment color. And you can see that very early on, the endocrine treatment is already becoming very prominent. But you can also see that in the lowest group, active surveillance is still very rare, and most of the patients are treated by radical prostatectomy, and that continues through all stages. That is the United States, and it may be different in Europe, but I thought that this is very informative. Now, my time is limited, and so I have decided to skip the review of the Scandinavian SPG4 study and the controversy that has developed after the publication of the American PIVOT study. The Scandinavian study uses a clinical population and shows a significant improvement of overall survival and cancer-specific survival. The PIVOT trial uses a mixed population with about 50% screen detected and does not show such difference. But in the subgroup analysis that looks at the clinically detected cases, there's also a significant difference. So most likely, in my view at least, and I'm sorry that I cannot give you the whole story on this, radical prostatectomy does lead to an improvement of overall and cancer-specific survival. Now, instead of going into this, I'm just showing you here the results of two very large studies that were analyzed together, Dr. Cardolona's and Dr. Walsh's study from the United States. You can see that if you do radical prostatectomy on a clinically detected case, the 5-year survival is 88%, 10-year 81%, and 15-year 76% in this very large population of men. Now, we have also conducted in Rotterdam a comparative study of radical prostatectomy between the screening and control arm. 42,376 men included in the study. And in the screening arm, we found at that time, that's 2 years old, 1,151 prostate cancers. In the control arm, 210. And radical prostatectomies were carried out in 36 and 24% of these cases, 420 versus 50. And the endpoints of which I show you are progression-free survival, metastasis-free survival, and cancer-specific survival. This is the progression-free survival. You can see that the screening group does significantly better with a estimated 10 years, so we don't have the 10-year follow-up of about 80 to 90%. This is the metastasis-free survival, and you can see again there's a significant difference. And this is the overall survival. Again, there's a difference, but the difference occurs very late during the study period. So in conclusion on this, I think we can state that radical prostatectomy does offer advantages above active surveillance, but again, we need to identify the proper cases, and your help worldwide is urgently needed in developing MRI to help us to avoid the overdiagnosis which governs much of this result. I'd like to then concentrate on endocrine treatment and discuss with you the issue of early versus delayed treatment and the combination of endocrine treatment with treatment of the primary tumor. The first information came in 1967 from the Wakirk study published by Mellinger, and it seemed to show that that endocrine treatment could be delayed until metastatic disease occurs, because there was no difference in the outcomes if the endocrine treatment was given early or late. However, the data are not credible because this endpoint is an endpoint that was not part of the initial power calculation. And we have learned that the primary tumor reacts more favorably to the endocrine treatment than the metastatic disease does. This gives you an overview over the issue of early versus delayed endocrine treatment, a recent meta-analysis published by Dr. Verhagen in 2010 in European Urology. And you can see here, if we look at overall survival, that there is a 10% advantage in early treatment, so this contradicts the Mellinger data, and that is statistically significant. And if we then look at cancer-specific survival, we again see a significant difference, now highly significant, and the difference is 21% plus minus 5. So there's very little doubt with looking at all the available trials in a meta-analysis that there is a marginal advantage, small advantage of initiating endocrine treatment early. This obviously needs to be balanced against the side effects of treatment. If I have in front of me a patient who comes in with his 20-year younger wife and they are very eager to maintain their sexual function, I will help him to understand what the side effects of delayed endocrine treatment are, but help him to maintain his sexual function. So this all needs to be balanced and delay the endocrine treatment. So how about the primary tumor? Do we have to treat the primary tumor with endocrine treatment in advanced disease or not? This is the question of the next few minutes of my presentation. The first study addressing the issue was the ECOG 3886, a study reported by Dr. Messing in New England and in Lancet in 1999 and 2006. And the study was underpowered, never reached the sample size calculation that was established up front. The follow-up is long, talking about 10 years average here. And you can see if we look at early endocrine treatment and overall death or prostate cancer-related deaths, that overall 7 of these men died in the early endocrine treatment group, and of the 7, 3 died of prostate cancer. If we look at the delayed treatment group, then we see that 18 of 51 patients died overall, and that 16 of these 18 died of prostate cancer. Now, these are data that have changed clinical practice in the United States and in many centers in Europe, in spite of the small sample size, and this made people believe that endocrine treatment plus radical prostatectomy should be the treatment of choice in patients who have lymph node metastases. Now, radiotherapy. There's a wealth of information on this, and I'd like to concentrate on the EORTC study 22863, reported by Dr. Bolla several times, for the last time in 2010. 415 patients randomized between 1987 and 1995. 50 gray to the pelvis is a dosage that wouldn't be used presently anymore, so that was at the time this trial was started, it was a common dosage used. The endocrine treatment was 3 years of an LHRH agonist, goserelin in this case, and the treatment was introduced with cyproterone acetate for 1 month. The median follow-up at this time is 9.1 years, and the 10-year outcomes show significant hazard ratios in favor of the combined treatment with hazard ratios of 0.6, 0.38, and 0.42, and they're all statistically significant. This shows the cancer-specific survival curve, which amounts to more than 30% at the median follow-up, and the overall survival curve, which amounts to about 25% difference in favor of the combined treatment at the median follow-up of some 9 years. Now, this leaves the question open. See, this is randomization of radiotherapy with or without endocrine treatment. It leaves the question open, does endocrine treatment alone do the same thing? And that is addressed by another trial that I'm going to refer to with my next slide. The trials on radiotherapy plus hormones or radiotherapy without hormones represent very hard data in my view, and they show the biggest advantages in treatment of all the trials. The differences in radical prostatectomy are much smaller, but there's no big study comparing radical prostatectomy plus minus hormones in this setting. The mechanism of the interaction between endocrine treatment and radiotherapy is unclear. we don't know if there is a direct effect on the N+ disease, either by the radiotherapy or the combination of both. The endocrine treatment only arm is missing, and the treatment of the primary tumor seems necessary, but we don't understand why. Now, the circle closes with the SPG7 study, reported by Dr. Whitmark in Lancet in 2009. It's a study of endocrine treatment with or without radiotherapy. So here we have the endocrine treatment only arm, and it shows that after 7.6 years, reductions in overall survival and prostate cancer-specific mortality amount to 32% and 56%. And these are very large differences, and they confirm that endocrine treatment alone doesn't do the trick. So we do have to treat the primary tumor in this setting, locally advanced disease, plus minus lymph node metastases, and add endocrine treatment. Now, there's much progress recently on the management of endocrine-independent disease, or castration-resistant disease, as it is termed now. It is not covered in my presentation for time reasons. The knowledge about the fact that androgen synthesis continues to take place and that the androgen receptor remains active in castration-resistant tissue of prostate cancer is the main basis for the progress that's made. And the two drugs that are prominent at the moment are abiraterone acetate, enzalutamide, or MDV 3010, developed in New York. Xtandi, these are the predominant drugs. They all show in a setting of chemotherapy-resistant cancer at least 5 months advantage in survival and treatment. Other drugs are sipuleucel for immunotherapy and RAD223, that is a new drug for isotope treatment. Now, a few words for the rest of my time on active surveillance. Active surveillance is applied to men who are eligible for curative treatment. So the aim of active surveillance is curative, is to save lives and to avoid prostate cancer death. And that is very different from watchful waiting, which is initiated with palliative intent. These are some of the inclusion criteria of the biggest study around at the moment, and I'm going to go through this very quickly because my time is running out. This is the study with the longest follow-up of active surveillance, the Canadian study by Dr. Klotz. Follow-up 6.8 years, reported in 2010. More recent reports, oral reports, have become available. And the study shows that of 117 cases treated curatively after they experienced progression, the prostate cancer death rate at 6.8 years was 2.8%. Now, the 5-year progression seen after radical prostatectomy or radiotherapy, as you can see, is 38% and 57%. And this, in my view, is reason to be very careful in advising active surveillance, because we have to consider the risk of missing lesions that occur during the follow-up period. So in my view, the inclusion criteria, the follow-up criteria, and the trigger points are still subject to investigation, and my colleagues agree with that, and that leads to the consideration of peasant risk, and I think everybody who is considering active surveillance should have an informed consent signed. So how should we deal with present uncertainties? As I said, our biggest hope is the development of MRI to avoid overdiagnosis. And this could lead to the introduction worldwide of prostate cancer screening. At this moment, we are tied to prostate risk calculators, which don't include MRI yet, but we hope that it can be included very soon. The decrease of overtreatment by applying active surveillance is absolutely crucial for the further development of the field. T3 disease can be cured at a high rate of 25 to 35%, depending on the endpoint you look at, if treatment of the primary tumor is combined with endocrine treatment. You should not delay endocrine treatment if it is indicated, and new treatment options are available. This is my last slide. It shows an advice to men who want to be screened, who consider to be screened, and it shows the risks and the benefits. It is available for men off the street, and it's also available for urologists and GPs on the website of the SIU and on the website of the Movember movement from Australia as a formal decision aid that should be applied in this situation of existing uncertainty. Thank you very much.